Hello, I'm Dr. Amory Morse, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity titled Awakening Clinical Competence, Empowering Advanced Practice Providers in the Diagnosis and Management of Narcolepsy and Idiopathic Hypersomnia. Today's program is supported by an educational grant from Jazz Pharmaceuticals. Today's activity is brought to you by CME Outfitters, an award-winning, jointly accredited provider of continuing education for clinicians worldwide. Today's activity offers the following credit types. This activity may include discussions of products or devices that are not currently labeled for the use by the US FDA. The faculty have been informed of their responsibility to disclose to the audience if they will discuss off-label or investigational uses, any uses not approved by the FDA of products or devices. So I'm Dr. Amory Morse, as I mentioned. I'm the Director of Child Neurology and Pediatric Sleep Medicine and the Program Director of the Child Neurology Residency Program at Geisinger Janet Weiss Children's Hospital. We have an incredible faculty with you today, and I'm really privileged to be with Dr. Michael Thorpe. Dr. Thorpe, can you please introduce yourself for me?
Yes, Anne-Marie. I'm a professor of neurology at Albert Einstein College of Medicine, and I'm director of the Sleep-Wake Disorder Center at Montefiore Medical Center in the Bronx, New York.
Wonderful. And I am also equally excited to have these two incredible powerhouses of women be alongside us today. Maggie, can you please provide a brief introduction for our audience tonight?
Thank you, Anne. I'm Maggie Lavender. I'm a nurse practitioner who works under Dr. Gerald Simmons at Comprehensive Sleep Medicine Associates in the Woodlands, Texas. I've been a nurse practitioner for almost 13 years now, and my passion is helping patients in sleep, especially with narcolepsy and hypersomnia.
Awesome. And last but definitely not least, someone who is a very near and dear friend of mine. I frequently will joke with her that we've known each other since our sleep infancy. Because I had the exquisite opportunity to meet her when I was a sleep fellow, and she has greatly shaped my personal and professional trajectory around how to best advocate. Julie Flagar. And I would probably say that you're probably the person on here who does not need an introduction, but please, if you could provide an introduction for our audience.
Thank you, Anne-Marie. I'm so excited to be with you guys today. I'm Julie Flagar. I was diagnosed with narcolepsy, with cataplexy when I was 24 years old, and that was 17 years ago, so a long time ago. And I run Project Sleep, is a nonprofit to make sleep cool. I also published a memoir about my story 12 years ago, I think, 13 years ago maybe, called Wide Awake and Dreaming, a memoir of narcolepsy.
Wonderful. I always like to say that as an Italian girl from New Jersey, Julie's a perfect example of turning lemons into limoncello. And so with that stated, really giving an exquisite representation of when you remove the glass ceiling from individuals living with narcolepsy and appropriately diagnose and optimize treatment, there really is nothing that can stop them. So let's get on to the rest of the content for today. This is our disclosures, which are important for you to take a quick look at. And so let's take a quick look at what our learning objectives are. So our first one is to assess the impact of diagnostic delays in idiopathic hypersomnia, narcolepsy, and their associated comorbidities. Number two is to differentiate the effects of treatment selections on idiopathic hypersomnia, narcolepsy, and associated comorbidities with an emphasis on cardiovascular risk and patient-specific considerations. And finally, evaluate the sleep-wake cycle and its relationship to narcolepsy and idiopathic hypersomnia to optimize its evaluation and management. So I always think it's best for us to use lived experience. And so what better way to do that than to utilize a case to help in really understanding. And so we really want to clear this diagnostic fog to be able to describe a better story. So let's meet Jane. Jane is a 34-year-old woman who presents with insomnia. And so many times people do come in with this self-diagnosis because that has been what maybe their primary care has shared, or even potentially they've self-diagnosed because this is what they've heard their friends say. So she comes in complaining of insomnia, characterized by this unrefreshing sleep and mental fatigue. And then she says, I work full time. However, I'm really struggling with focus and performance. I utilize caffeine in order to help me get through my day, sometimes 3, 4, 5 cups. And I maybe even sneak out a Diet Coke in there as well. And she's reporting that she's not necessarily having the best diet and she has very irregular and erratic routines. This is a story that I think is very representative of many times the average American as you're hearing this. And so how are we deciphering this from anything else? Now, to add more to this diagnostic fog, she's experiencing some depression and anxiety. This is longstanding and managed with an SSRI. Now, with that, she's also on hormonal therapy. She's newly married. She's not planning any pregnancies in the near future. She reports that she can have some occasional palpitations, not surprised with the excessive caffeine intake, but could there be anything else? She does have an elevated BMI and blood pressure. Again, not too atypical for the average American. 75% of the United States is overweight to obese. And she may possibly have undiagnosed OSA. This has not yet been ruled out. So what do? We're hearing this story. She's having unrefreshing sleep. She's having a challenging daytime performance. So one of the things I think is really important about looking at the story to start with is her complaints are, yes, my sleep, I think it's insomnia, but it's all based on daytime symptoms. This is an important reminder not to separate day and night. So what do? We do a home sleep test, and that's not showing any significant sleep apnea. We have to remember home sleep tests are really for those who have a high likelihood for moderate to severe OSA. And unfortunately, a young woman like this may not fit that criteria. So we now are going, you have no sleep apnea, but you're still telling me that you're not feeling great during the day. And so they very appropriately ordered a PSG MSLT. However, they failed to educate her on that. Perhaps you should take off your SSRI. That can suppress your REM, that can alter the test results. And what did they find? An MSL, an average sleep latency of 9 minutes, and no SOREMs. Her polysomnography demonstrated a significantly increased arousal index, and then she also had no OSA identified on that. Her sleep onset latency in that was normal, but there was no actigraphy or sleep logs that were obtained prior to testing, understanding what her normal sleep-wake schedule looks like. Remember, she has an irregular schedule. So the symptoms were attributed to psychiatric history, and they continue to go along with this idea of insomnia, rather than considering hypersomnia or hypersomnolence disorder. The current pharmacology continued to be an SSRI with intermittent use of stimulants and modafinil from her prior prescriber. And sometimes we even see this in regular clinical practice of being utilized for an atypical depression. So I just want to pause there for one moment just to ask the team, is this a story that you've heard? And I think that this is something that from an advocacy perspective, Julie, I would love to hear. Are these the stories that your rising voices are sharing in terms of what their own personal journey, or just that you've heard anecdotally as being someone who's been in the field for so long?
Oh, for sure. I think sleepiness and depression are hard to untangle. I'm looking forward to getting into that in a little bit. So yeah, this is something that you could definitely see happening, especially when once there is a psychiatric diagnosis. It seems like that's all some providers can see. They can't really see beyond it.
Yeah, and that really is that diagnostic fog. Maggie and Michael, what are your thoughts? Is this something that you're commonly encountering?
Yes,
Well, the
we often see-
insomnia. Go ahead, Maggie.
It's okay. I was gonna say we often see this exact patient come in with the complaint of insomnia, and they've been to many providers, and they just keep giving sleep aids to help the insomnia, but then it doesn't help. They feel overly tired and cognitive fatigue in the morning, but yet they still not sleeping well at night. So they're just not getting to the root causes.
Yeah.
Yep, that's very common. I mean, I often see patients who they're having complaints of tiredness, fatigue, even sleepiness, and then they think, well, the reason that I'm tired and fatigued is because I'm not sleeping that well at night. And so the focus gets on to the insomnia, and they go down that path of investigation.
Wonderful. So this is where we need you guys in the audience to now participate and tell us about your practices, because you're here to be able to improve your clinical practice. And that's what we're here for as well. So which of the following pre-diagnostic steps do you most often use before ordering an MSLT for suspected idiopathic hypersomnia or narcolepsy? It is important to know that there is not necessarily any wrong answer. This is for us to be able to understand, what are you typically doing? So for Maggie and Michael, in your clinical practice, number one, do you have access to actigraphy? I would say that many clinical practices do not have access to this because, number one, they are very expensive to purchase. And then number two, there's very low reimbursement. So it's hard to be able to build a practice around a tool that we can't necessarily cover to keep our doors open. So what are your guys' experience with that?
Yeah, well, sleep logs are the simplest way to measure what's going on with somebody's sleep. So I think that in anyone that's tired or sleepy, you really want to know information such as when are they going to bed at night, when are they getting up in the morning, are they napping during the daytime? And you can get that information very easily from sleep logs. So if you don't have actigraphy available to you, certainly sleep logs are so simple to get and provides a wealth of information.
Absolutely. Absolutely. And I would add, so one of the things that I've added to my practice is everyone's wearing some sort of consumer wearable. And so although I'm not going to say on here, I'm advocating to say that they're medically equivalent, what I will say is they're giving me a really good thing to compare to that sleep log to be able to better validate and understand.
Yes.
Wonderful. And so as we're looking at this, we are seeing that a lot of people are doing a lot of really great work out there in a relatively even spread of looking at sleep logs, doing two or more weeks of sleep logs with actigraphy. They're doing the overnight polysomnography only, or proceeding directly to the PSG MSLT. Some of this sometimes gets dictated by insurances. So I do think that it's important. Now, Dr. Thorpe, I am going to reflect on what Jane's story is and recognizing what the content of this is. I'm sure that we are not having a spoiler alert around this, of that she probably does not have insomnia. But why are patients like Jane being misdiagnosed or being missed? And it's not just sleepiness.
Well, complaints around sleep are extremely common. I mean, either difficulty in sleeping at night or tiredness, fatigue, sleepiness during the daytime. And, patients have other things that are going on in their life. They have busy lifestyles. They may be cutting themselves short of sleep. And, people think, well, maybe that's the reason I'm not getting enough sleep at night. That's why I'm tired and sleepy during the daytime. Or they may have comorbidities that are occurring too, such as feeling depressed, feeling down, and even anxiety can affect people's ability to sleep at night, so that they're more tired during the daytime very often. And patients always don't always know how to explain what's going on to them, with them with regards to their sleep. So they don't use the terms that we're used to in clinical practice. They don't come in saying, I'm very sleepy during the day. They may say there's fatigue and tiredness, and it may be due to an underlying medical or psychiatric or sleep disorder, and you need to tease that out. And there are many things that can influence a patient's symptoms, and because these complaints of tiredness, fatigue, and disturbed sleep are so common in our society, it's very easy to get misdiagnosed.
Yeah. And before going on to the next slide, one thing I just want to address is there's a great question that has come in, and it's stating many of us see patients with overlapping depression, anxiety, and fatigue. Based on your experience before sleep testing, what is the most reliable clinical clues that points towards IH or narcolepsy rather than a primary psychiatric illness? And what I would say based on this slide, that is a really important call to action for you to walk away with, is just as Dr. Thorpe has just stated, is that people don't typically come in saying I'm excessively sleepy, but they may have some of these red flags that are written across the top. The person who said I had a motor vehicle accident because I fell asleep behind the wheel. The person who's saying I am having reduced intimacy with my husband because of the fact that I'm just too exhausted, I'm too tired, I'm too fatigued. And when you get into that and go, what do you mean by that? I'd rather sleep, right? I'd rather be able to go to sleep. Julie, from a patient perspective and an advocate perspective, have you heard of different ways that people may have used the lexicon in a variety of ways that,
Yeah.
again,
Yeah, we definitely have
helpful?
slides on it too, but coming up, I think a little bit more so. But I think the question that is really important, especially for type 1 narcolepsy, would be when you say you're like tired, like if you had the chance to lay down, would you actually fall asleep? To help distinguish from something like depression or fatigue, which is more like a sensation, which people with narcolepsy can experience too. But at least for type 1 narcolepsy, I think really that ability to some people will say like, oh, absolutely not. Like I would just lay there with my eyes open. But for at least maybe type 1, and maybe you guys have a better sense of type 2, and maybe not necessarily for IH, that's more of maybe long sleep at night, but I could fall asleep. I was falling asleep in a dental chair in the middle of having dental work, falling asleep on a boat, falling asleep before a softball game, having trouble driving. So I really was actually falling asleep.
Yeah, I think that those are really important. Dr. Thorby, walk us through this nighttime sleep disruption, because I think one of the things that many times people misperceive is that people who have these conditions are just these great sleepers. And I think that the reality that people need to walk away with is that sleep-wake disorders are called sleep-wake disorders because they are interfering with both.
Yeah, well, I think something that most people don't sort of realize is that narcolepsy is a 24-hour-a-day disorder. Patients can't keep awake during the day, but they have difficulty with sleep at night. And the sleep part of it at night often gets overlooked. But as you can see from this information, this is from 3 major studies looking at sleep in patients with narcolepsy compared with controls. And I think it's best illustrated by the center histograms there, where you can see significant differences in that patients with narcolepsy tend to have lighter sleep and more stage 1 sleep, less of stage 2, less of a deep slow wave sleep. And so that sleep can be quite disturbed in these patients and disrupted. And you have to remember that that's a major part of narcolepsy. I mean, we think of narcolepsy as three major symptoms: excessive daytime sleepiness, abnormal REM sleep phenomena, of which cataplexy is one, and then disrupted nighttime sleep. And this slide certainly illustrates that.
Yeah. And I think some of the other things is that when we're looking at sleep-wake disorders, there's a variety of things that can cause disrupted nocturnal sleep. And even in individuals with narcolepsy, there can also be other sleep disorders that can contribute: REM behavior disorder, periodic limb movement, obstructive sleep apnea. And so it can make that diagnostic journey a little bit more challenging. And if that's not enough to cloud the picture and make it feel overwhelming, it gets back to the question that even was posed in our questions earlier in the presentation is, we see that there can be these comorbidities. And so certain comorbidities that can continue to cloud the picture is that they also can have these other medical diagnoses that can also be associated with sleep dysfunction as well as inadequate wakefulness. But we also are seeing that there are risk factors that individuals living with narcolepsy may be higher likelihood to experience, such as things like stroke, hypertension, hypercholesterolemia. And when you're looking at individuals living with narcolepsy and looking at health claims data, we do see that there can be up to a 2-fold increased risk of cardiovascular comorbidities. When we go back to our patient Jane, her comorbidities are signals, not distractions. We recognize that people living with hypersomnolence disorders, about 40% can have either a comorbid diagnosis of a psychiatric or mental health diagnosis, but also it can mimic a mental health diagnosis. Overlooking them delays accurate diagnosis and risks prescribing treatments that worsen her true condition. It's not just sleep, it's also making sure we're considering cardiovascular health, her elevated BMI, her hypertension, her mental health diagnoses, and then also the hormonal factors. She's currently on hormonal therapy, as well as not interested in currently being pregnant. Now, Julie, I want to turn this over to you because we do want to talk about the missed, the masked, and the misread. So tell us a little bit more.
Yeah, so this is from a study that we did, and it mirrors a lot of other research around the world that shows there's long delays to diagnosis between 8 to 15 years average, and then some people go much longer. So 25-year, 30-year delays between symptom onset and diagnosis can be, can happen. And it's happening to a lot of people. My experience, I guess I was the lucky one. I was about 6 years between my symptoms beginning and getting diagnosed. For me, even about 5 years in, once I was having trouble driving just 15 minutes in the morning, and remembering my drive, and I went to a primary care doctor. So at this point, I actually realized I think I might have a sleep problem. And when I told the primary care doctor, I think I might have a sleep disorder, her response was, well, everyone gets sleepy when they drive. Even I have to pull over and get a coffee sometimes. And it was really strange because I didn't know how to compare her sleepiness to mine. Like, I don't know. It's not something that is measured, right? So I just remember a small voice in me thinking, I don't think we're talking about the same kind of sleepiness, but I had no way of knowing. And I think that mirrors a lot of other people's experiences as well.
Yeah, and I think that that's also what we're starting to see Jane experience. And one of the points that I just want to highlight and emphasize is that it's a sad day that we're saying that a 6-year delay in diagnosis is being one of the lucky ones. So not to diminish your journey, but to highlight that is one of the things that we are referencing.
Yeah, I mean, that can be someone's whole high school experience, their high school and their college experience, their high school, college, first job, second job. And as you often internalize these things, you just think, I'm lazy, I'm just not good enough. And you just expect less of yourself. So it can't be underscored how serious it is. And we've talked about some of this about language. I just wanted to add that, that we talked about the sleepiness versus kind of like depression, or fatigue, and that, if you actually lay down, could you actually fall asleep? But there are other things, like even with cataplexy, one person said that her family described like you lose your smile when you laugh. And so it's an interesting thing, or you kind of look drunk when you're laughing. And so there's all sorts of different terms and ways of describing this. And a lot of it's honestly really invisible. It's not like the movies, people with narcolepsy are not collapsing over asleep. And we are really good at adapting, right? So we adapt to our circumstances. For me, getting tired in the middle of art history lectures in college, I just thought, because it was like really boring artwork, or the room was too hot, or I wasn't a morning person, or I hadn't had enough caffeine, or I'd had too much caffeine. So, it's really important to look for any clues that you can and help parse this out with your patients.
Yeah. And I think as we go into the next slide where we're evolving the diagnoses, it's important to reflect on what was the initial diagnostic testing. So although there was a home sleep test and a PSG MSLT, it is important for us to specifically call out her MSLT was not normal. It was non-diagnostic. It did not meet the criteria as outlined by the ICSD-3-TR. However, it was a pathologic result where this is a 34-year-old person who fell asleep on five naps in an average of 9 minutes. That is very objective data of excessive sleepiness. And remembering that she was on an SSRI, which may be suppressing those REM findings that could have shown up on the PSG as well as the MSLT. So Dr. Thurpey, please walk us through the evolving diagnoses.
Okay, well, once we recognize that a patient has a problem and that they have excessive daytime sleepiness particularly, then we need to get some objective documentation of that. And the way we do that is through a multiple sleep latency test, which needs to follow an overnight sleep study because we need to exclude sleep apnea or some other movement disorder that may be contributing to sleep disruption at night and causing patient to be sleepy during the day. but if a sleep study shows that there isn't any specific pathology such as that, then we do a multiple sleep latency test, a 5-nap opportunity during the daytime, and we look to see whether the patient falls asleep quickly or goes into the REM sleep, which is particularly abnormal. So that falling asleep in less than 8 minutes is usually diagnostic for narcolepsy, and 2 or more sleep onset REM periods during the 5-nap opportunities. However, we know that people who are sleep deprived, people who have obstructive sleep apnea syndrome, they can also have those findings. They can fall asleep very quickly, and they can have sleep onset REM periods. In fact, they can even have as many as 5 sleep onset REM periods if their REM sleep is very disrupted with, say, obstructive sleep apnea syndrome. So we need to recognize that there are other reasons that patients may have those particular findings, and shift work, insufficient sleep, sleep apnea are some of the things we need to consider if they are particularly sleepy. So just getting a test result is not the end answer to understanding what's going on in a particular patient. And on the other side of the picture, false negatives are very common. About 20% of patients with narcolepsy won't show the diagnostic features on the multiple sleep latency test. And this may be because of they may be very anxious about undergoing the test, and their anxiety may increase their alertness during the day. Medications, and of course we saw that with Jane. She was on psychiatric medications, which could have affected the MSLT. And so the MSLT needs to be performed under ideal conditions. And we mentioned that you need to make sure that the patient isn't sleep deprived. So getting sleep logs or the actigraphy before is an important factor. It's not always done. And therefore, a patient may come in and they may be sleep deprived and falsely get a positive test, or there may be some other reason why they get a negative test. So the MSLT, it's an aid to diagnosis, but it's not the end answer. And we often need to repeat the testing, and we may get a different result. In some patients, particularly those with type 1 narcolepsy who have cataplexy, it's a little bit more robust in that the findings don't change a lot if you retest. But in somebody who has narcolepsy type 2 or idiopathic hypersomnia, there may be some variability in that test if it's done at different times. So getting the test done at under the ideal conditions is certainly important to get a good diagnosis.
Yeah, and I would also just add that we always have to use history. And so I think it's important to remember in medical training, we get very much taught that history is what provides our diagnosis. Tests are what support the diagnosis we're looking for. And an individual like Jane, her story is saying that this is not a primary psychiatric condition that is driving her symptoms. And the fact that the sleepiness is so prominent also makes me really question the diagnosis of insomnia, being that a hypersomnolent version of depression is actually the rarer form and tend to be more refractory, which also raised the question as to, are we treating the right thing? So if we go back to Jane's case, we are seeing she's diagnosed with this insomnia, depression, anxiety. She's on the SSRI. She's continuing to have these insomnia-like symptoms. She's prescribed a sleep aid. She's continuing to escalate her caffeine use. She's still sleepy. She tries modafinil because modafinil is a great off-label medication for the treatment of depression. And so you can see where she's getting masked and masqueraded as an inappropriate diagnosis, and she may have some modification in her symptoms, but ultimately her symptomatology may be best explained by something like narcolepsy type 2. And her outcome is that she's having inadequate resolution, but also experiencing some of these adverse effects, both from the caffeine self-medication as well as the modafinil. So, Michael, if we were going to say what would be best-in-class care for Jane, how would we test well for her?
Yeah, well, we need to do that MSLT under ideal conditions. And so one of the concerns, as you mentioned, was the fact that she was on antidepressants. And ideally, the patient should be off these for at least 2 weeks before undergoing a multiple sleep latency test, because they can influence not only the sleep latency, but also the number of sleep onset REM periods. So we need to carefully assess the patient for at least 2 weeks before they undergo a multiple sleep latency test, either by those sleep logs and or the actigraphy, as we mentioned, but also make sure that any medications that they're on that could influence the test are withdrawn prior to the testing. And then when the patient comes in, want to make sure that the patient's getting an adequate amount of sleep. We want a minimum of 7 hours of sleep before doing a multiple sleep latency test so that there is no element of sleep deprivation. And the other factor is that the patients need to be sleeping at an appropriate time. So if somebody's going to bed at 3 a.m. in the morning and getting up at 10 a.m. and you do a multiple sleep latency test starting at 7 a.m., then you may get incorrect results because you may well get sleep onset REM periods that are inappropriate to the patient's sleep-wake pattern. So performing the tests at the appropriate time in the 24-hour day is very, very important. And you have to remember, as I mentioned earlier, that you may get a falsely negative test in some of these patients, and you may need to repeat the test at a later stage. So doing the test under ideal conditions is absolutely crucial to making a good diagnosis.
All right. Well, I know we have a lot more to get through, so we're going to keep chugging along. The good news for Jane, she was being taken care of by a provider who actually attended this CME and has changed the trajectory of her journey. So they went back and said, you know what, I was all wrong. And it is an important thing to recognize that time is our best diagnostic tool, and sometimes new education information allows us to recognize the person who's sitting in front of us and how we can improve on the care we're delivering. They implemented pre-test sleep stabilization. They gathered the logs. They followed the best practices. And she now is living happily with that husband, and they have a new bouncing baby boy. So let's get back to your role in early recognition and diagnosis. And so Maggie, help us understand how we can empower our advanced practice providers.
So we already know that APPs, we play a very vital role into helping our patients understand the disease state and helping understand what their symptoms are and the connection to the symptoms to the disease. So we are trained, we know to do the appropriate workups by questioning the patients, really getting that good history so we can get the diagnostic going. This leads to shorter diagnostic times because we've performed the right test. We didn't waste any time. By knowing what we're doing from the get-go and understanding it, ordering the right test, we're reducing the risk of missing that diagnosis or getting the wrong diagnosis. This also will strengthen your trust system with the patient. If they really feel that you are listening to them and not just saying, oh, insomnia, keep going. Let's, really listen to their story, ask appropriate questions so you can understand what is it, why is it affecting them. And this builds our trust and our expertise and your own confidence that you can handle not only that patient, but the next one and the next one. We did a survey of about 62 physician's assistants and NPs, and we learned that about 42% we are actually doing the initial diagnostic testing correctly. So that is amazing. We were there. So let's keep going with it. And then we're also able to identify truly what is cataplexy. 56% of us did that. Can we understand what the results are of an MSLT and the SOREMs? What do those actually mean? Can we explain it to our patients? And then also, what is the difference of sleep inertia versus I'm just tired in the morning? What is that unrefreshing nap? What does that make a difference in what diagnosis we're going after? So keep it up, guys. We're doing a great job. Keep doing our good deeds for our patients here.
Wonderful. So now we have successfully diagnosed Jane. How are we going to learn how to balance those risks and benefits? And this is where we need you to, again, engage in this audience response system. When selecting a treatment for idiopathic hypersomnia or narcolepsy, which patient factors most influences your choice? I think the individualization, the personalization of care is a very, very critical element. For myself, it's really getting to understand what can't a person do because of the burden of disease that they're experiencing, and then understanding what are the other factors in lifestyle and social interaction and all of the other components to be able to say what is the right treatment. Because I think one of the things that you're going to hear from Julie later is that treatment is not limited by just pharmacology. And Maggie also is going to be layering in those lifestyle and behavioral, but also Julie will be highlighting that very, very important pillar of social support. And so when looking at these different potential options, it is important to recognize that all of them can play a role, and therefore being able to really individualize which of these and how is that going to impact medication or additional lifestyle, behavioral, social support. I would say the thing that no one is allergic to and that you won't see adverse effects from is going to be engaging in a community, so you feel less stigmatized and alone. So it looks like we have a good amount of responses that are coming in, and we should be seeing some of these results populating soon. And so, not surprisingly, not surprisingly, we do see insurance coverage and access, but we also see patient lifestyle preferences. That is going to be very important. So I think we see a very good diverse range. Now, what's important is what's approved and what's off label. So looking at what your tools in your toolbox are, this is a great slide that you should definitely print out and be able to look at later on, of talking about the different treatments that may be available to consider and then what their mechanisms are. We're going to quickly just go through a couple of clinical trials that have looked at one of those features that we've introduced and perhaps you hadn't recognized previously, which is disturbed nocturnal sleep or disrupted nighttime sleep in a sleep architecture. And there's a study called Duet that has looked at this. And what they're identifying is that we do see that with the utilization of things like oxybate medications, that we can see that there is an improvement of this disrupted nocturnal sleep in individuals with narcolepsy. The same feature was not studied specifically in idiopathic hypersomnia. We also see that with the studies looking at narcolepsy and idiopathic hypersomnia for individuals with pitolisant, what we're finding is that this wasn't a feature that necessarily was captured. It's important to recognize that pitolisant does have an approval in narcolepsy, however, does not yet have an approval in idiopathic hypersomnia. And then lastly, one of the things that you will encounter, especially when you're treating an individual with idiopathic hypersomnia, is sometimes they will encourage you, and insurance will encourage you to utilize something like modafinil. However, it is an off-label. There is only one on-label treatment that is available with an FDA approval for idiopathic hypersomnia, and that is your low sodium oxybate or mixed salt oxybate. Now, when looking at the modafinil, we can see that it does have an approval in narcolepsy. It has not been studied for disrupted nocturnal sleep, and idiopathic hypersomnia, although it's not approved, there have been studies, and those studies really have been kind of inconclusive as to whether or not there is a significant degree of benefit there. So this is where we are going to want to go back and talk about the balancing risks and benefits. And Dr. Thurgby, I'm going to ask you to just make some comment in regard to the cardiovascular health and treatments.
Okay, so a number of years ago, say 10 years or more, we didn't really pay any attention to cardiovascular issues in narcolepsy because we knew so little about it. But in the last 10 years, we're really recognizing that the cardiovascular factors are very important in narcolepsy. And so we want to reduce anything that might exacerbate any patient's tendency to develop cardiovascular disorders. And one of the things that we need to think about is the patient's sodium load, and there, when we come to using oxybates in the treatment of narcolepsy, some have sodium associated with them and one of them does not, and so that may be a consideration that we need to think about. And then the stimulants, of course, are notorious for stimulating cardiovascular parameters, particularly heart rate and blood pressure, and so you need to be very cautious in your use of those, particularly in someone who has some cardiovascular issues. And even caffeine. Jane was using caffeine, and you know, if one takes it to excess, that certainly can increase anxiety, irritability, and increase cardiac rate as well. So basically we need to consider all these factors and other factors, the other comorbidities that can occur, the psychiatric comorbidities and the medications that are taken for psychiatric disorders that may also exacerbate cardiovascular considerations. And we want to make recommendations to our patients about good lifestyle factors that can be helpful, such as avoiding sodium and also maintaining a good sleep-wake schedule, which we know is important for overall health. And so talking to the patient and good shared decision-making with the patient is absolutely essential when balancing the risks and benefits of medications.
Yeah, and we're going to want to think about briefly some of these safety considerations among the treatment options, which I think you've already hit on a lot of these considerations. Is there any specific things that you want to add?
Well, I think it's important that we recognize that there are great differences between all the medications that are used for narcolepsy, and some of them, such as pitolisant and modafinils, can affect oral contraceptive agents. Jane was on an oral contraceptive agent, so we have to take that into consideration. There are newer agents which are not metabolized in the liver, such as solriamfetol, and so this could be a good alternative, and it's an effective alerting agent. As we move forward with the newer medications for narcolepsy, we're tending to avoid the use of traditional stimulants like methylphenidate and amphetamines, which certainly we know can make cardiovascular issues a greater concern.
Now, Maggie, we're going to come back to you and help us to understand what our APP's role in monitoring and managing comorbidities can be.
So again, it's very important for APPs to really understand and talk to the patient to see what is going on in their lifestyle. How can we change dietary habits, exercise, increasing that fluid intake to really work, stop eating the french fries, to lower their sodium intake if we're really thinking about bringing oxybates on board. Understanding what is their cardiovascular risk. We know that hypersomnia and narcolepsy patients do have a higher risk. Do they have a family concern? Are they dealing with obesity? What is their risk factor whenever we're choosing medications? When we look at NPAs and NPs, we do have confidence in identifying the difference between IH and narcolepsy, because there's a big difference there. Understanding that, again, the patient's lifestyle, and can we choose cardiovascular safe medications? Is that a big priority on our list for their lifestyle? And then what are the key triggers? Is the excessive daytime sleepiness the biggest portion that we're dealing with? That 82% of us believe, yes, that is. And then looking at what is the unrefreshing naps, truly understanding the difference of IH and narcolepsy and how do we treat that and go after that, because that makes a big difference in how we decide on our treatment management.
Wonderful. And so we're coming back to you for our audience response, because I think we're going to be getting into one of the most important topics. Because we're going to be turning it over to Julie about which non-pharmacologic approach do you most often recommend to patients with IH or narcolepsy? Maggie and Michael, what are some of the things that you may potentially consider? Is this something that you find is just as important and is a part of your prescriptive pattern of describing? Because I think that this is something that is a care gap in many practices.
Yes, I spend a lot of times talking with my patients and truly figuring out what changes can be made in their lifestyle on a daily basis to help, because medicine can only go so far. Yes, medicine is great. We have it and we have the ability to use it. But if the patient's not doing what they can do, then that may possibly mean they need more medicine on board that comes with more side effects. So let's fix what doesn't, have to be with a side effect, and the easy fixes in our daily life. So education, education, education.
So Julie, this is where I want to turn it over, because really the goal needs to be, how do we empower people?
Yeah, well, I think it's really careful when you're talking about non-pharmaceutical strategies to also remember not to be shaming your patients and not to be telling people, like, of course, there are like 1,000 things everyone could do, we could all do to improve our health on a daily basis. And you have to be careful sometimes, like, to understand that when someone is extremely sleepy, and especially when they're starting a diagnostic and treatment journey, not to be overloading them with 100 things that they can do better. It's just not practical, and it might actually make people feel more shame and more self-guilt. I
That's
think
such a
that's a
great point.
really important message when we're talking about these non-pharmaceutical approaches, especially, talking about changing people's diets and everything. Another thing to understand is that, of course, napping is really important. And so far, as far as the pharmaceutical treatments have come along in the last 20 years or so, I don't think that everyone has been able to get rid of napping as a strategy. Napping is still really very much a pillar of treatment for many people. So it's important to talk about those logistics of how you're going to incorporate, possibly 30 to 45 minutes in the middle of your day, maybe once, maybe twice, and where are you going to do that, and how you're going to feel safe to be able to take that rest that you need. So, also, as you're thinking about helping your patients, I think it's important to remember, like, as new treatments are coming out, maybe you don't have familiarity with every treatment, but not to let that stop you from your patient being able to try something new. I hear that a lot, that a patient becomes empowered about a new treatment option, takes that to their provider, and that their provider actually says something to the effect of like, oh, that's difficult to get covered with insurance. And it comes down to that the provider has never, had a patient on that. And so don't let that stop you, and don't let that stop your patient from having a better quality of life potentially. And working with them, and use your clinical community to help support you. Other people have tried those treatments. They've gone through clinical trials, and help people to be able to try new treatments. We're all going to have to try new treatments, you as providers and us as patients.
Wonderful. And it is important for us to specifically call out when we're talking about those pillars of treatment: medications, naps, coping strategies, social support. So if you are making a point to prescribe a medication, please make sure that you're also prescribing these things, including social support. So Maggie, tell us a little bit about other behavioral strategies that may be helpful.
So as we talked before, sleep-wake consistency. You can't be going to sleep at 10 p.m. on one night and 1 a.m. the next night and 4 a.m. the next night. Your brain is never going to understand when it's supposed to be asleep and when it's supposed to be awake. So stick to a good schedule. Talk with the patient. What is best for their lifestyle? What time do they need to be up for work? Do they have kids to manage? Are they, working on an opposite schedule of, instead of working during the day, do they work at night? How can you help them get on a consistent schedule? Get to that morning activation. Get up, turn on the lights, open up the windows, get some sunlight in. Let's start working with our natural body responses of cortisols and melatonin levels. Use your body as a tool. And then caffeine. We know we all go to caffeine to get us through that next meeting or that next, whatever we have to do. But just understand that we're not saying you can't have it. Just let's get a better understanding of how much are you actually taking. Because some of us don't even know. We just keep grabbing that cup. So actually, how much are you actually taking? And then talk about the timing of it. You can have it, but stop at this point of time during the day, because it will affect your ability to go to sleep at night. We have less sleep at night, then our daytimes are struggling again. So truly understanding what your habits are. And then daytime support. If you know your afternoons are going to be your hard time, let's not eat that carb loaded spaghetti meal for lunch. Like let's work with what we know, get those lighter lunches. Use snack time, strategically place those snacks to help us out. And then naps. Yes, we give our patients permission to sleep during the day, but it's strategically placed at a certain time when they most need it. And I'm not giving you permission to sleep for 4 or 5 hours during the day. So
okay, we don't need permission from anybody. Sorry, Maggie, but people's sleep habits aren't permission or not. So
I get it. But understanding that it's not 5 hours during the day to help them know that they could benefit from a shorter nap there. And then good evening wind down. You have to prepare your brain for sleep. We live in a very fast-paced world with all of our commitments. Start teaching our brain how to wind down. Prepare yourself for sleep, and that prepares you for better success the next day. So truly sitting down and talking with your patient. And like I said, Julie brought up an amazing point. Don't overwhelm them all at once. Pick the easy ones. Start there. But first you have to understand what their day involves and then what could be improved, and give it to them, spoon feed them a little at a time.
Yeah. And I think that this is where, again, I think Julie will get into this around the social support aspects, is don't pretend that you know what it's like to walk in the shoes of an individual with this condition if you don't have that condition and actually know how to walk that walk. And this is where social support and community can be very helpful. Also, as you're looking at some of these things, these are sometimes the call to action. I would say with the caffeine, if I'm finding that I'm treating an individual with medication and that they're still utilizing a high quantity of caffeine, that for me is the call to action of, I need some optimization of looking at the full picture again to see how can I better empower this person to have consistency, because I want them to be able to live with predictability. And I agree with you, Julie. I think that the term permission is not necessarily us saying we permit you, but more of saying like, this is not something we want you to be ashamed of. And I think
Correct. It's okay to
utilizing,
do it.
yeah, and I think utilizing, just as you had stated, the right terminology is something that can be very empowering to our patients. And just to, in closing this section, can we briefly just go over some of this like high level personalizing pharmacologic treatment selection and monitoring patients with IH?
Yeah, so I think again, what are the patient's needs? What are their preferences? Again, understanding their life. I could tell you whatever medicine I want to do for you, but if that doesn't work into your lifestyle, you're going to fail at it. So really work with what's important to them. How does it work? What is their ability to be successful with the medicine? Of course, we're looking at cardiovascular risk. Yes, I may want to put a patient on oxybate or pitolisant, but that takes a little bit time to kick into effect. Is the patient unable to drive during the day to get their kids to school? Maybe we need to interact with a stimulant initially to get to that severity of EDS to buy some more time for them. Then continually, once you prescribe something, you're not done with the patient. You always have to assess and reassess to see if we can change the treatment plan or how are they working. Is this working for you? Do we need to add something else? And then prepare the patient. What are the possible side effects from this medication? Educate them of when they need to talk to you. Is this dose specific, and is this going to get better, or is this, yes, this medicine's not correct for you and we need to definitely change over? Also
Wonderful.
look at what are they also doing that could be additive to a medication you're prescribing, and maybe the increased heart rate is because they didn't tell you they had that much caffeine and you added a medication. So really just understanding and talking with that patient.
So we are going to now put Julie back in the steering wheel to help us better navigate and putting the person first.
Yeah, so there's a lot of stigma with narcolepsy and IH, and there's been only one study, and it shows that people with narcolepsy experience levels of stigma comparable to people living with epilepsy, multiple sclerosis, and HIV. Those are really high levels of stigma. You should definitely check out this paper by Mary Capella. So people, when they are diagnosed, we did a study of over 1,300 people, and at diagnosis, about 90% of people with narcolepsy or IH did not know someone else living with the same condition, which isn't too surprising because, you know, when it's a rare condition, maybe unless you have someone in your family that has hypersomnia, you might not know someone else. But even at the time of this survey, so this could be many, many years, about 30% of people still don't know someone living with the same condition. So that's 1 in every 3 of your patients have not interacted, met, feel comfortable asking a question to another person. So just imagine going to, you know, to school as a healthcare provider, going to med school, nursing school, or whatever, without knowing anyone else going to that same school. How would you become educated? How would you learn to live your best life? You can't do it without peers and mentors, people to look up to and people to walk that journey with.
Yeah.
And this is just a slide that shows that a large percentage of people felt that knowing someone else with the same condition helped them to, you know, had a very positive impact on their experience.
I think a really important point, because the fact that that slide was not appropriately representative, I want to make sure that people hear exactly what your study demonstrated, because I think this is really important. At time of diagnosis, I'm alone. 90% of people feel alone. And I'm saying they feel alone because they don't know anyone else, right? We didn't actually ask, do you feel alone? But at the time of this survey, which was a survey that was distributed by an advocacy organization, a third of people still do not know another person living with it. And so to add on to what your illustration, which has been the most impactful to me as a clinician of, imagine being a medical student going through that. Imagine being a physician or an APP 5 years into practice and still being the only one.
Yeah. So a really great call to action for you is you can take someone's phone and have them pull up websites of nonprofits. So it's actually on their phone, or you can hand them brochures or let them know patient groups exist and they have different programs and different offerings.
Yeah. And I would say the quickest way to incorporate that into your practice is using some smart phrases, that this way it's a matter of a dot phrase that you can make sure that they can walk out of the hospital with, and they can also be able to look back into it to look at. So go ahead, Maggie. I want you to go through these last couple of slides, and then we do have a few questions that I'm hoping that we'll be able to answer a few of.
Perfect. Well, this is going to be quick. We just want you to know that you're not alone into that interprofessional sleep disorder team. It takes all of us to work together to help understand what's going on with our patients and lead to diagnosis and treatment. Shared decision making. We need to involve our patients in being a part of their decision making, empower them, educate them of what are your options here. This is all the treatment options I have. Again, what works with your lifestyle? What works with raising kids, what works with being a single parent, what works in your crazy life during the day. Involve them and teach them so they can be a part of that decision making, and they're going to be more successful versus you saying, okay, you have this disorder, here's your prescription, I'll see you in a month. Help them understand this is our options, or maybe they want to try option number D down the line, but you got to get through A, B, and C with insurance. And so just educate them. Hey, we're going to try this, but this is our ultimate goal because that's where you want to be. So just have them be a part of it. And then what is our actual role? Again, I can't repeat it enough. We have to educate and be a part of that care. We have to improve adherence and engagement by constantly asking the patient, how are you doing? Are you actually, tell me how you're taking the medicine versus are you taking it as you should? What time of the day are you taking the medicine? Are you, having difficulty going to sleep? Pose specific questions versus putting the patient on the stand and accusing them of not doing what they're supposed to do. And this builds the trust that they can open up to you. Because Julie, I'm sure you can say for this, once you have a hypersomnia or a narcolepsy patient, you gave them treatment and they get a little bit better, and then they're so scared that you're going to take that away from them. So just build that trust that you're not taking anything away. You're only trying to help it work better for them. Or if this is not the option, you're going to figure out what is right for them. Bridge that gap between feeling like there's a wall between the patient and you as the specialist. Get down to their level and help them understand. Use the proper normal language. Get away from the medical jargon so they can talk with you and have that open conversation. And then 2, adapt educational roles. If you got to bring it down to their level, use the language that they use at their home. If English is not their first language, then guess what? You need to go find resources that uses it in their first language. And I don't let any single patient of mine walk out with patient advocacy information because I truly feel it takes a village, and the village is not only the medical providers.
Wonderful. So let's, we only have a few minutes left, but there are some really important questions that have come through. So first and foremost, how do you navigate helping a patient with disability accommodations? So first I'm going to ask Julie, from a community support, right? You are providing social support. I'm sure that you're not going to say these are prescriptive things, but
No,
I do
we
think
have a
part
whole
of it.
toolkit about accommodations. Everyone's different. Every patients with different. So we have toolkits that help provide examples of different accommodation ideas and, example letters from the doctor. So you can look at that too. So definitely there's a lot of support out there. Lots of different organizations have information about how to support people with disability accommodations, whether that means, just finding accommodations at work or actually even going through the Social Security disability process.
100%. And Dr. Thorpe and Maggie, any additional thoughts around that one?
No, I think, with regard to accommodations, it's very important to involve the patient in that. And what I'd like to do is that sometimes a patient will say, look, I need a letter for work or for school or for some other situation, and they want me to write it. But what I'd like to do is to get them to do the first draft, because it's often that you find that patients will come up with things that you may not have thought of being particularly important in that particular patient. So involve the patient in trying to get accommodations for work or for school, for example.
Yeah, there's one more question that I want to make sure that we answer. But one of the things stated, you show data across modafinil, pitolisant, oxybates. How do you personally sequence or combine these therapies in practice, especially when patients have partial response but ongoing EDS? So one of the things that I'm a neurologist and I'm a sleep medicine specialist. And so to make this so that people can feel what this actually may be, right, is that many times we minimize the experience of sleepiness. However, we shouldn't. I make the analogy to how I approach epilepsy, and I'm going to make this so that people can understand in a clear fashion. I introduced my first medication. For me, this may be whatever the patient is saying is going to fit in my life. If you're tolerating it well, but you're having partial resolution, For me, I'm going to be saying we're going to add on a second agent until we get complete resolution. Once we get there, we then see what can we take off for you to live optimally and successfully. And so this is where you do want to make sure that you're understanding what are your goals of care and how are we able to continue moving. And so with that, I know that we are running out of time. And so I want to make sure that I'm sharing with you SMART goals. SMART goals are specific, measurable, attainable, relevant, and timely. Put information in action. You got chock full of information and as well as many tools today. Considering the following goals, then set a time frame that fits with your work environment and a reasonable improvement target that aligns with your patient population. Incorporate sleep logs, actigraphy, and pre-test sleep stabilization into diagnostic workflows for patients in suspected IH or narcolepsy. You heard from Julie Flygar. Please do not make your patient feel stigmatized and guilty for when this may be challenging, and making sure that you are partnering with them and putting yourself at an even level. We're not dropping down. We are just saying we are elevating the conversation so that we are peers. We want to include cardiovascular risk assessment, psychiatric comorbidities, and patient goals in every treatment plan discussion. And we're going to provide structural behavioral guidance, sleep-wake cycle, caffeine timing, lifestyle modifications. This is not unique to narcolepsy or IH. This is something we're having a conversation with all our patients about, alongside pharmacologic information and interventions, to optimize patient outcomes. I would like to thank Maggie, Michael, and Julie for this incredible discussion and hopefully impactful resource for all of those who have attended and those who are going to be accessing it later. And I also want to thank CME Outfitters for their assistance in developing today's program, as well as those of you who had commented that this was a very impactful session and that the social isolation and social support was something that was new knowledge